was interviewing straight into an ICU. It was a high acuity medical surgical ICU in Salt Lake City, Utah. And the nurse manager brought me into her office and said, "Hi, come on in, sit down." And almost immediately after asked me point blank, "Would you be willing to walk intubated patients?" And I was so new that I didn't exactly know why she was asking that, what that meant. And I was like, "I'll do whatever you teach me to do."
Probably good that you
What,
were new.
they hired a lot of new grads there intentionally so that
Mm,
they started with a blank canvas. But she
mm.
said that that's standard. And again, I didn't really know exactly why that was a big deal. And I started working there, and no one made a big deal out of the fact that almost every single patient was awake right after intubation. Obviously, they would be sedated for the procedure of intubation, those induction meds. But as soon as those meds wore off, they'd be awake, writing on a clipboard, and we'd walk them through this process of acclimating to the endotracheal tube. And an hour later, they'd be just hanging out in bed on their cell phones, right, typing on their computers, sitting in a chair, walking around the unit. And so, because no one made a big deal out of this and everything was new to me, I just took it in stride. It made sense to me. Of course, my patients are human, so they're going to be awake during the day, asleep at night, communicating their needs, mobile, going to the bathroom and the toilet in the corner of the room. We're just going to scoot the ventilator over to make that happen. Like it just, I never questioned it. Um, and so I did that for a few years, thinking that that was normal, not a big deal. I loved it. I had such sacred experiences with my patients. So after a few years, I know I was young. I was about 24 at the time, single. I want to explore the world. So I became a travel nurse. And no one really told me about what the outside world was like.
Mhm.
My mentor, Polly Bailey, she's a nurse practitioner there. She actually started that process of care. I didn't understand her history or why she was such a big deal. But she's mentioned, it's going to be different elsewhere. And that's all I knew. So when I went into a new ICU, my very first shift, I walked in there. It was day shift, but all the lights were still down. Every single patient was in bed. It was so quiet. It was eerie. Um, and I got my patient assignment. Then I had an orienting nurse with me, and one of my patients was intubated, and I wanted to continue my routine. As a nurse, we have
Yeah.
our routines. You've got your brain lets it out. You've got your routine. You're gonna do what you know. Well, what I knew was talk to my patient, have my patient communicate back to me, do a full neuro exam, probably get them into the chair to wait for physical therapy to come. But I couldn't do any of that because they were laying there motionless with no response because they were sedated. And there was nothing about their acuity or their diagnosis that helped me understand why they had this sedative going. There were certain reasons in my first ICU, like status epilepticus. If they had the severest of ARDS in which they couldn't oxygenate with movement, boom, they'd be sedated, right? Otherwise, I walked people on a PEEP of 18 and 100% with vasopressors. So I was looking for the reason as to why the sedative was going and I couldn't identify it. So I asked the nurse that was with me, orienting me, "Hey, can I get sedation off and get him up?" And she responded with such shock and horror and said, "Well, no, they're intubated," which shocked me. But anyways, I'm like, okay, objectively, these are very sick patients. I felt like I started to realize, was I gaslit? Was I led to believe something that wasn't true? And so I was also in grad school at the time, getting my doctorate in acute care gerontology. And I was surrounded by professors and colleagues that were very experienced in critical care medicine and in the ER that I respected a lot. And even in my classes, we'd be going through case studies, and a patient comes in the ER with pneumonia and they get intubated and they were hemodynamically stable before intubation, but now they're on propofol and now we're starting vasopressors because now they're hypotensive. And I'm looking around and everyone's just nodding their heads like this is normal. And I'm asking, why are they on propofol? Why, if they're hypotensive, are we giving them propofol? And they're looking at me like I'm crazy. So that led me to finally look into the research. And by that point, it was like 2017, 2018. And there was research about this showing the risks of sedation and immobility. My own hospital, I didn't know this, but that team was the first one to publish in 2007 showing that it was safe and feasible to walk intubated patients, even with a median PF ratio of 89, which means that these lungs were very, very sick. and they were walking these patients, and the adverse event rate was less than 1%. And I'm like, well, someone could have mentioned that to me. This ICU was like pioneered what we now call the ABCDEF bundle. So it inspired a lot of the following research on early mobility in the ICU, keeping patients awake and mobile. I was working in that very first ICU and had no idea because by then it was so normal that it was what everyone did. Unfortunately, without being empowered as a nurse to know why we did it, when I
Mm.
went to a normal culture, I still fell into this is what we do because everyone does it, but in a very harmful and even lethal way. And so I really regretted that. I thought if I had known what I'm learning now, I wouldn't have done these things.